welcome to our Facebook Live question and answer session this month. I'm Dr. Rami Kaldas of the Kaldas Center, and we are looking forward to answering your questions. All of the questions, as many as we can fit in to the short time we have. Thank you to everyone who submitted questions on Facebook already. If you have not sent in your question yet, feel free to post it on Facebook Live, and we will do our best to get to it. If you'd like to submit an anonymous question, by all means, please contact us using Facebook Messenger and indicate that you'd like to share your question, but remain anonymous, because we want to have a good time and talk about whatever everyone wants to talk about. Nothing is too crazy or embarrassing. There's no such thing here. Before we begin, a reminder that this question and answer session is meant to be informational only. If you have serious health concerns, make certain to contact your doctor. If you'd like to contact us at the Kaldas Center, visit kaldascenter.com or call 920-886-2299, and we'd be glad to visit with you. Remember, no referral is ever needed to visit the Kaldas Center, regardless of what you may have heard or hear. Absolutely no referrals are required, since we're board certified OBGYNs, even though we take on all these fancy situations. So the first question comes to us from Angie. Do you have recommendations on exercise routines based on each phase of a woman's monthly cycle? I hear you're supposed to take it easy some weeks. You can exercise to your fullest extent during other times of your cycle. Well, I don't have specific recommendations for specific routines during the menstrual cycle. However, you'll find that you can mostly exercise throughout the cycle. You'll find that because of hormonal levels changing, estrogen and progesterone, that you're going to feel like you have more energy at times than others, Angie. And so what you'll find is that sometimes, especially if you have a lot of PMS symptoms, you actually may want to exercise because that may help, all right? And it may affect your energy depending on how much bleeding you're doing, because some women who have very heavy periods actually can get anemic, or they have a low iron associated with their very heavy menses, and their energy level is temporarily reduced during that time period. There are some people who say you shouldn't do certain poses in yoga and Pilates when you're having your menses, and that has not been so well studied. I don't believe that it worsens retrograde menstruation, though you'd think it would. You have to remember that every woman has retrograde menstruation. 100% of women do, unless you've had a tubal ligation or your tubes removed. And it's just the 10 to 15% that the immune system doesn't clear it out, end up with endometriosis. But anyway, so I would say that I haven't written out specific exercise routines for people, but I bet you'll be surprised at how you can remain doing most of what you do during your menses. Obviously, swimming may, if you have a heavy period, may be a challenge, and so you may need to stick to the land-based exercises in that situation. Thanks, Angie, for that question. Today, we have a question from Jillian. I have a family history of fibroids. How often should I get checked for fibroids? And what are the treatment options if I have them? Oh, great question, Jillian. So there is a component of a hereditary component to fibroids, and it is recommended to have an annual exam, an annual pelvic exam, even though pap smears are recommended every 3 to 5 years if you've had a history of normals over the past several years, all right? Unless you have a new partner or something like that. But when you have your exam, if your uterus is enlarged, your gynecologist should be able to tell. And if they can't tell for sure, then they should get an ultrasound. Otherwise, I would say that you don't need routine screening beyond that unless you have symptoms, Jillian. So if you are having a lot of pain or heavy flow that can be associated with fibroids, then get checked out. Come to your doctor. Have an exam, have an ultrasound done. Find out where those fibroids are. Obviously, if you are postmenopausal, they're less likely to be growing. That's not impossible to grow after menopause. The biggest fibroids I've ever taken out have been in menopause, because a percentage of them do continue to grow in spite of the lack of estrogen in menopause. Obviously, if you're thinking about fertility, then you may be having this in the back of your mind frequently and thinking, oh boy, my mom had a hysterectomy because of fibroids. I don't want that to happen before I have my kids. And so you just go and like I said, make sure your uterus is of normal size and contour with your doctor. And if she can't tell or he can't tell, and then get that ultrasound done to figure it out, because fibroids when they're small, even when they're right inside the cavity, actually for the qualified a person who knows how to do hysteroscopy, which is unfortunately not a majority of our colleagues, but it's really easy to take care of hysteroscopically, really easy. If they get bigger, things may not be so easy anymore. So go on the basis of symptoms, Jillian, and go on the basis of findings at the time of your routine exam. This is an anonymous question. I have vulvodynia. The pain is so bad that I cannot use tampons, ride bikes, have sex, or sometimes even walk. This is very bad. I've seen physical therapists, and from what we can determine, this is nerve pain. What would you suggest for this? What kind of specialist would you recommend? I'm very tired of chronic pain, and I'm at a dead end. This is a very frustrating situation, and I've seen a great many people with vulvodynia, and the thing with vulvodynia is you really want to be sure that you've ruled out all of the pathophysiologic possibilities. So you can break them down into 4 different types: an inflammatory process, an infectious process, a neoplastic process, or a neurologic process. So let's just go briefly through those and be sure that your gynecologist has ruled out that this is something that's not going on. So for example, an inflammatory process is lichen sclerosis, for example, or psoriasis, or lichen planus, and that will end up being proven by a biopsy. If you have vulvodynia or all this time and no one's done a biopsy yet for so many years, and you've got burning and pain and on and off or continuously, that should have been done because you need to figure out what's going on there. That could be totally remedied. I've had people come to me who thought they had vulvodynia, who in fact simply had candidiasis, the yeast in the skin of the vulva, for up to 6 years without being diagnosed. 6 years. It was deformative. And and I've had others, for various amounts of years, chronic candidiasis, healthy people otherwise, and I just put them on antifungal for a month, and it took care of it, and they thought that I was a genius, but it was just a matter of recognizing what that looked like. So that's an example of infectious. Or for example, herpes, okay? Or shingles even can happen of the vulva. So if you look at the inflammatory, that's infectious. Then inflammatory is like lichen sclerosis, psoriasis, we said. And then neoplastic is like, do you have precancer of the vulva, all right? Someone should be able to tell that. Or it could be, neurologic, like even a slipped disc, okay? If all that is ruled out, then there could be a vestibulitis going on. And vestibulitis is thought to be an autoimmune thing where you have this redness at the back of the opening of the vagina usually, and it's exquisitely painful to touch with a sterile Q-tip, and that can be mapped out. And in the worst case scenarios, when medications are not working, you can even do a resection of just that back part of skin and do a flap from the vagina with over a 90% success rate if that is only side effective, all right? Now, that's if it's vestibulitis. If it is generalized vulvodynia and nothing can be found, then I would recommend something like amitriptyline, starting at a low dose, or gabapentin, all right, that inhibit the transmission of of pain through the nerves, all right? Because the best way to look at vulvodynia that doesn't have a physiologic origin is that at some time in your life, probably, there was some kind of trauma to the vulvar skin, and the pain receptors there are still firing as if there's a phantom pain, and there's this continuous burning, and then you just have to stop that transmission of the pain down the nerves to the brain, to the prefrontal cortex, and that is best done with amitriptyline or gabapentin. Unfortunately, some states are starting to make gabapentin a controlled substance also, and DEA is getting involved with that. And so, but not all states have done that. I know Michigan has done that. If you're from Michigan, that would be a little bit of a challenge. You're going to find some resistance with your doctors to provide that on a continuing basis because of that. And that's unfortunate because it has been a useful medication so far. Thank you for that question. So a reminder, if you would like to set up a time to speak with us at the Kaldas Center, you can call us at 920-886-2299 or visit kaldascenter.com. So from Tashonda, would you recommend Addy to patients? It's the female pill of Viagra. Well, I wouldn't necessarily recommend it if you don't need it. I mean, you want to use, explore options that are non-pharmacologic first. Obviously, there is a role for medications to help with libido and ability to orgasm, but you want to be careful with it, and you want to make sure that you're into the person you're with and that you're not having lack of libido because it's uncomfortable because of possible, say, what we were talking about, yeast infections or pain with intercourse or from endometriosis or something like that. So there's a role for it, but once you have tried to figure out why it is that you're having sexual dysfunction, that's what I would say about that. Another anonymous question. I had my endo scraped with laparoscopy in 2016. I noticed the cramps throughout the month and back pain coming back this year. Is that typical? How often will I need laparoscopy? Oh, that's a great question. So the key word here is scraped, okay? The best way to treat endometriosis, if you're not trying to get pregnant, is to remove the lesions. And I'm seeing this very regularly in our practices at the Kaldas Center, that most GYN surgeons are simply uncomfortable removing the endometriosis. They go in and they scrape it or they burn it, and whenever they say the word scraped, that to me is right there a concerning sign that it wasn't taken care of. Just in the last couple of weeks, I've had two patients where the surgeon actually took pictures of the endometriosis. There were big nodular lesions, and then she dictated that there was no endometriosis. And then another one simply took an ovary out, and the woman actually had stage 4 endometriosis. She was told, it didn't say anything in the op report about the endometriosis being removed. She told the patient at her postoperative visit that it had been taken care of and that she had to be on Lupron, otherwise it would come back. So my gut tells me that your endometriosis was not actually adequately treated, it was not removed, and then your symptoms are more likely to come back sooner. If it is actually removed, then the best thing you can do is avoid periods, and that is pharmacologic then. That's going to have to be with some kind of hormone, and then modulating the estrogen. That is not necessarily with Orlis or Lupron, okay, but rather because you actually removed it then. With laparoscopy, with excisional therapy. But then you can do, say, a low-dose contraceptive pill or agestin with letrozole to modulate the estrogen so as not to cause it to be stimulated in return. So you're preventing the period, preventing the retrograde menstruation, modulating the estrogen that feeds it until you're ready to get pregnant if you ever want to, and then you go off and you try to get pregnant in a timely manner. That's what I would recommend. So I would say that it is variable. There's a 50% overall recurrence rate for endometriosis, and but 50% of the people don't need recurrent surgery for endometriosis. And believe it or not, we consider 2 years to be successful. If you can get out to 5, that's fantastic. But you also have to consider what I just remarked about, and also the possibility that you have adenomyosis that's very hard to take care of, and very few people are trained to actually excise adenomyosis or shave it out hysteroscopically and wedge it out laparoscopically, but it is totally possible in a fertility-preserving manner. So, from Cynthia, are there tips and tricks to getting pregnant with only one fallopian tube? Ha! Fabulous question. You lie on your side. No, not at all. And so what it is when you take one fallopian tube out, you actually reduce fertility by 10%, not 50%, Cynthia. So in fact, there are many, many people who have had 5, 6 children with only one fallopian tube or one ovary, okay? And if you have both ovaries still, you actually ovulate from the opposite side and it goes into that fallopian tube. So with your fertility being reduced only 10% with one fallopian tube missing, then I would say that there's no tips or tricks. But there's a caveat, Cynthia. If your other tube was removed because of an ectopic pregnancy, you're going to have about an 18% chance of another ectopic pregnancy. Therefore, it is absolutely essential that when your quantitative HCGs are high enough, that you go into your gynecologist, your obstetrician, and you get an ultrasound to make sure that pregnancy is in the uterus and not another ectopic, because if you catch it early enough and you're amenable to it, you can just treat it with methotrexate and not have to have another surgery that might risk losing your remaining tube, and then there would be a requirement for in vitro fertilization. So I'm predicting success for you this year, Cynthia, with one tube. So from another anonymous writer, how common is infertility in men? If it is the man's issue, what can be done? I find it difficult to even talk about it with my husband. Oh boy, what a great question. And so infertility is thought to be, in a couple, is thought to be about at least 20%, usually 40%, as most literature says. It's actually the male factor more than the female factor. And so about 15% of women suffer from infertility, and I would say about that same percentage for men. It depends on what's going on with the guy, the treatment that would be appropriate. Obviously, a semen analysis, a very good one with strict criteria, what we call Krieger's strict criteria, would be a good idea to do. And then you can find out if the fertile male is having a varicocele, like varicose veins of the testicles that are heating them up too much, and that's causing the sperm count to be not so great. Fixing the varicocele helps about half the time. Putting someone on Clomid, yes, guys can go on Clomid, can also help with sperm count. But if there's a lot of deformity, like really low normal forms for the sperm, it may be required to actually do IVF with intracytoplasmic sperm injection under 2,000-fold magnification with a glass needle, because when they're deformed, frequently what it is that the tip of the head of the sperm, the enzyme is missing that helps burrow, that like dissolve the eggshell to get into the egg. And if that's missing, you can have a whole bunch of sperm, but they're just going to be bouncing off that eggshell, and they're just not going to be making any progress and be getting, kind of frustrated, and so leading to your frustration because you're not getting pregnant. But it is, there's never an infertile person. There's always an infertile couple. This is something that I'd encourage you to approach with your partner or your husband. And I would say that that most guys are more uncomfortable even talking about this than women who have fertility challenges. And you've just got to help him through it. He chose you because you're a wonderful person, and he adores you, and so he'll do this for you. From Alexis, in order to start the conception process for a woman with endometriosis and PCOS, our average patient, is it necessary to have the laparoscopic surgery for best results? It depends on what you want to do, because laparoscopy does remove the, if you're going to remove it, right? Let me qualify it. If you're actually going to treat the endometriosis correctly and actually take it out, okay? Take the endometriosis without taking organs out, without taking the uterus out, without taking the ovaries and tubes out, then laparoscopic surgery profoundly helps you to get pregnant, if you're going to try to avoid in vitro fertilization, okay? So most people, I'd say 80-90% just don't need IVF, and they can get rid of the pain frequently associated with endometriosis and the pain with intercourse and all that if they have the procedure and a day's surgery, and then try to get pregnant on their own. A lot of people, in fact, half of them probably will get pregnant on their own, just getting rid of the endometriosis. And then if that doesn't work, my usual protocol is that If within 3 to 6 months they're not pregnant, then I do controlled ovarian stimulation cycles, which are more successful if you've gotten rid of the endometriosis. So endometriosis reduces fertility. There's no two ways about it. That's been widely published in many sources. From Lauren, after endometriosis excision, what would you advise for people who still have chronic constipation, urinary frequency, nausea, etc., that is consistent with nerve involvement? Oh, that's an excellent question. All right, so with the urinary frequency, obviously about half of people with endometriosis will have something called interstitial cystitis, which is also thought to be autoimmune mediated, just like endometriosis is thought to be an autoimmune disorder. And endometriosis is also a neurologic thing. You have 3 times the neurotransmitter that transmits pain to that prefrontal cortex if you have pain with endometriosis. And so you can try regimens that are to treat interstitial cystitis, and then also try regimens for that pain transmission modulation, like amitriptyline or gabapentin. As far as the constipation goes, I would say that you're going to need to use things that are usually used for constipation. If it's more irritable bowel syndrome type of thing, is kind of tricky figuring out, is it IBF or is it endometriosis still? And I would say this, after the excisional therapy, talk at that post-operative visit with your doctor. He or she really needs to show you what they have done to know that it has been excised. I guess I become a bit of a skeptic. Make sure that it was actually excised, not just that someone says it was excised and you have like one specimen was sent to pathology. And ask to see your pictures, ask for a copy. It's your right, and you need to watch out for that for yourself. Okay? So, from Beth, do you treat menopause, lifespan health at the Kaldas Center? What are the treatment options? We treat menopause at the Kaldas Center most certainly, and we treat all associated issues with menopause, including vaginal dryness, including dyspareunia, pain with intercourse, including incontinence of urine. We do an awful lot of treatment for that, since we are, to my knowledge, the only ones doing the laparoscopic non-mesh approach to incontinence that just really changes people's lives. And also pelvic relaxation syndrome, the issue of the bladder falling, the rectocele, people having difficulty having bowel movements in menopause and so on if they've had children vaginally. And so, yes, we do treat the entire spectrum of things, and we also administer hormone replacement therapy when appropriate, if that is what is right for the individual. It's all individualized. It's all getting to know what the goals of the individual patient or client are. So, just a reminder, to speak with us, you can call us at 920-886-2299 or visit kaldascenter.com. And no referral is needed. If we don't get to your question tonight, we'll follow up and connect with you in the next few days online. So Nikki writes to us, I had endometriosis on my ureters removed. Research says that I should have a follow-up on my kidneys. How often should this be followed up on? I would say that getting a creatinine and either an ultrasound or a CT urogram or something to confirm that everything is fine, like about 6 months after the surgery, would be a very good idea. All right, to make sure there's no narrowing of the ureters, to make sure that that your kidneys are working, because endometriosis, as you know, Nikki, can be very insidious, and you can actually lose a kidney because the endometriosis grows through one of your ureters so slowly that you don't have pain with it. That happened to one of my patients about a year ago, and she went to the Mayo Clinic to have a nephrectomy, and then came to the Kaldas Center to actually get rid of the endometriosis, because that's who could take care of it for her. But anyway, and so I would say that you also need to be aware, with treatment of endometriosis around the ureters, did part of the ureter have to be removed? Could there be a narrowing there? Could there have been devascularization? Because if the endometriosis is so close and the blood supply is compromised to the ureter, then you can actually get narrowing of the ureter and stenosis of that ureter. And so I would say that a follow-up 3 to 6 months later is a really good idea. Make sure that kidney isn't swelling up because of backed up urine in a very slow manner that you may not notice. So, and then after that, if everything is great at 6 months, I would say just follow your endometriosis symptoms. If there's a recurrence, check it out. I would make sure that your creatinine level is not going up on a yearly basis. So, an anonymous writer writes to us, I am 24 years old and I have endometriosis and do not wish to have children. Am I too young for a hysterectomy? Also, what are the side effects of a partial hysterectomy? If you are 100% certain that you do not want children, okay, then hysterectomy can be part of the conversation. And I have done that on occasion. And but I always ask my patients who have bad endometriosis, who want hysterectomy to be part of the solution so they don't get it back. It's far less likely that you get it back once you remove endometriosis. If you remove the uterus also, then you just want to be real clear. And I always ask them to imagine that they're 35 years old and they don't have any children and a bunch of their friends have children. Are they going to have any regrets? And if you say no, then you are an adult and you have autonomy over your body, and it should and can be part of that discussion and therapy plan. So, additionally, a partial hysterectomy in someone at 24 years old, meaning you leave the ovaries, okay, if it's done well, is going to actually do very well for you. The side effects should not be, if done properly, should not be falling bladder and falling, top of the vagina and all this and all that, and incontinence of urine and all that. If it's done properly, none of that stuff should be happening more frequently than if you hadn't had the hysterectomy. So thank you for that question. From Stacy, hi, is it safe to get a massage while trying to get pregnant and or pregnancy? Thanks. Absolutely, Stacy. Just don't have massaging on your belly, obviously, but I think it would be great to have a prenatal massage, and there are actually massage therapists who actually do prenatal massage almost exclusively. And so I would look that up and check it out. And in fact, I was with a massage therapist earlier today at Lake Park Fitness, and she does a lot of prenatal massage. I would encourage it. Obviously, you don't want to do acupressure on certain parts of the feet and so on, because you might set off some contractions. From Angie, how would you know if you had an ectopic pregnancy? Can you have an ectopic with IVF? Oh, Angie, you sure can have an ectopic pregnancy with in vitro fertilization, because the conceptus, once they put it in the uterus, actually is thought to go in and out of the fallopian tubes and settle in to the uterus. I do believe that the ectopic pregnancy rate with IVF is a hair higher also. So I had a very interesting situation where I actually had to remove hydrosalpinges, remove the tubes on someone who had, unfortunately infection from when she was a child in her belly, and because that they had, pus in them, and that was reducing her chances of pregnancy through IVF. So the person went through IVF, and she ended up with a twin pregnancy, but she ended up, in fact, with a cornual pregnancy, an interstitial pregnancy, where she had twin pregnancy right in the wall of the uterus, and it was just so sad, because hooray, she was finally pregnant, but if that pregnancy had continued, it would have ruptured and she would have bled to death because it would have blown out part of her uterus. So I had to take that out and on one side, and then put an occlusion for the part of the tube right in the wall, and then she had another IVF cycle, and then she subsequently ended up having 2 children by C-section. She had to have them subsequently at full term, but she went through a lot getting there. So always persevere when you're trying to achieve pregnancy. Anonymous writes, how safe is estrogen cream for a postmenopausal woman? By and large, it is safe. Mind you, if you have a strong family history of breast cancer or a personal history of breast cancer, then obviously you want to modulate your hormone replacement, okay? However, estrogen therapy, topically especially, can be ever so helpful. It's not as absorbed as oral estrogen and so on. And so systemically, and it can really improve issues with incontinence of urine because of atrophic bladder, atrophic cystitis, and also unstable bladder, and also decrease the issue of vaginal dryness and pain with intercourse associated with that. So I would ask your doctor about that, and I think I would consider it if they're having any of those symptoms. Thank you for the question. From Amy. If it's been close to a year since having laparoscopic surgery for stage 4 endo and adenomyosis, what steps would be taken if that person is still wanting to do IUI? Have the chances of becoming pregnant decreased significantly since it's been so long since surgery? Actually, if you have had excisional therapy for stage 4 endometriosis, all right, you have about an 80% chance of being pregnant in a year and 90% in 2 years. So it actually still, you have that second year, so you still have a 50% chance in that second year of getting pregnant if you didn't get pregnant the first year of trying, okay? And so the steps that would be taken is you simply go to your fertility person and you say, hey, I want to go ahead and try to get pregnant. It's been a year of trying since I got rid of my endometriosis. And then they should do a basic evaluation that the American Society for Reproductive Medicine recommends, like making sure your tubes are open, making sure your husband or your partner's semen analysis is normal, doing some lab work, seeing what your ovarian reserve is, because stage 4 endometriosis, especially if it involved the ovaries, can decrease your ovarian reserve, and it may be harder to get you to ovulate more effectively. And so just get that basic evaluation done with an informed fertility person, fertility specialist, and I have great hope that you will achieve success. So, my gosh, I can't believe it that we're out of time again. It goes by so fast, guys. Thanks for everyone who joined the conversation. If we did not get to your question, we will follow up with you in the next few days online. We'll be announcing our next Facebook Live in the next few weeks. Find us on Facebook or visit kaldascenter.com, and please join us and let's have a fun, informational time. A quick reminder that if you'd like to speak further with us, visit kaldascenter.com or give our office a call at 920-886-2299. As for tonight, thank you again for spending some time with us, and we hope you have a wonderful evening. Happy springtime, everybody.